Good afternoon. My name's Richard English and I'm Pro-Vice-Chancellor for Internationalisation and Engagement here at Queen's University Belfast. It's a great pleasure to welcome you as you join us online this afternoon for Queen's University's first ever TEDx digital event entitled Adapt and Change. TED is an organisation that aims to bring together the world's leading thinkers and doers to provoke conversations that matter and dialogue that helps us all. With the changes that we're all experiencing as a result of the COVID-19 pandemic, academic colleagues from across Queen's have responded positively to the challenge when invited to deliver a virtual TED Talk. They've taken the time to gather their thoughts on how change is affecting their area of work and expertise and to share those thoughts with us this afternoon. I'm sure that you'll enjoy the talks enormously. Please do get involved in this dialogue, engage with us via social media or email, share your comments and views on the ideas that we hear about today. If you use Twitter, please keep us in the loop by tagging the Queen's TEDx account at TEDxQUB, or if you prefer to email us at publicengagement@qub.ac.uk. A few words about the format of today's event. In a moment, we'll learn a little more about the TEDx brand when we watch a short video provided by TED. And after that, the President and Vice-Chancellor of Queen's University Belfast, Professor Ian Greer, will say a few words and officially open today's proceedings. We'll then hear in turn from each of our lineup of talented TEDx speakers, all of whom are members of the Queen's University staff. I hope you enjoy this digital event. And now first for the TED video.
Welcome to something special. Welcome to TEDx. This TEDx event is part of a global conversation that takes place every day in every corner of the world. In schools, in theatres, in workplaces, even in prisons, people gather to hear the best ideas bubbling up in their communities. More than 3,000 TEDx events are held every year in 170 countries. It's a remarkable thing. TEDx events are self-organized under a license from TED, a non-profit organization devoted to discovering and sharing powerful ideas in the form of TED Talks. It's not TED itself, but your local TEDx team of volunteers that has done all the work to put on today's event, including booking all of the speakers. It's this team's ideas, dedication, and time that have made this possible. We really hope today's program sparks an exciting conversation. This is a day for curiosity and for skepticism, for inspiration and for action. The more you enter into it, the more you will take out. And now, on with the show.
I would like to offer you a very warm welcome from all of us here at Queen's University Belfast. I'm delighted to mark the start of this, our first digital TEDx event, with support from our corporate partner, PwC. The TEDx principles and concept, in short, ideas worth spreading, very much align with our value here at Queen's. Giving experts a platform, sharing innovations, inspiring and encouraging new ideas, all in the context of an international community. For those of you who may be joining us from across the world and are not familiar with our university, perhaps I might say just a few words about the institution I have the privilege to lead. Queen's University is ranked 173rd in the world and is a member of the UK's Russell Group, made up of the country's leading research-intensive universities. As one of the oldest and most beautiful universities in the UK, we're committed to the highest standards of academic excellence, providing an exceptional student experience, delivering world-changing research, coupled with an international outlook and impressive graduate employability. One of the great things about TEDx is that the experts have the microphone. We should never underestimate the importance and value of expertise. Expertise that reflects long-considered opinions, thoughts and ideas. Expertise formed through extensive research, investigation and study. This TEDx event has been entitled Adapt and Change, something that many of us have had to do personally and professionally. Indeed, it's likely that you've had to adapt and change in at least some way over the last few weeks. Queen's University like all universities, is having to do exactly this. I'm very proud of how colleagues and students across the faculties have adapted and changed for these unprecedented times of the COVID-19 pandemic. We've seen medical, nursing and social work students embark on their careers early to join the front lines. Our virologists and clinicians are working tirelessly to research the disease and its treatment. Our scientists are playing a key role in increasing Northern Ireland's diagnostic testing capacity for COVID-19. Even some of our international students are organising an online charity concert. These are indeed challenging times, but it's clear that we're rising to that challenge together. And now to this TEDx event. It offers a glimpse of the exciting ideas developing at Queen's and reflects the general theme which spans many subjects, from healthcare to school education, and from the manufacture of new face shields to urban design. While there is much breadth in terms of topics in this digital event, I hope you'll enjoy the depth of these short talks also. These not only consider the current crisis, but look further ahead, looking ahead at how we as a society can emerge better equipped for the future. I'm now delighted to introduce the first speaker, Dr. Gemma Carney. Gemma is a lecturer in social policy here at Queen's and is involved in the ARC Ageing programme. Her talk is entitled Solidarity Between Generations During Lockdown. Enjoy the event.
If there's one thing we've learned in the past few weeks, it's that we're herd animals. Human beings share everything, including snot and spittle, according to the public health people. And we're far more dependent on one another than our pre-COVID lifestyles may have led us to believe. From about 1980 to, say, now, many of us Western Europeans at least were under the impression that we were individuals with rights to privacy, freedom to travel, and the money to enjoy both. But the lockdown has shown us that we are really interdependent. The weddings, birthdays, and holidays that have had to be cancelled, we're not going to be held alone. In countries across the world, highlights of life and rites of passage tend to be centred on large social gatherings of friends and families. So in some ways, for a social policy scholar like me, the lockdown's a bit of a boon. It allows me to demonstrate two things. First, solidarity between generations is everywhere. When the lockdown is lifted, the first thing we will do is hug our elderly parents or our young grandchildren. Second, social policy, which is the study of human welfare, matters. For years now, people in my profession have been fighting against neoliberal claims that there's no such thing as social solidarity, that people are free agents who can and should take care of themselves and only themselves. COVID-19, and in particular the physical or social distancing measures that have been brought in to halt the spread of the virus, have thrown all of that out. The lockdown has shown us how much we depend on each other and how much of that is intergenerational. Let me explain exactly what I mean by solidarity between generations. Solidarity between generations is one of those things that's so mundane, so everyday, so common, that like clean water and fresh air, it gets taken for granted. If you have children, when you got up this morning, you made them breakfast. You got them ready for school. And because it is the middle of a lockdown, you probably taught school as well. You may not be a great teacher. You're slightly confused about the precise definition of a pronoun, but you still did it. That is solidarity between generations. If you have parents, you may have dropped groceries off to your mum and dad who are over 70 and so not allowed to out. And if you're young, and if you're involved in a local sports club, you might be one of those young guys who've been putting together food parcels to drop off to older people who aren't related to you but still need the help. If you did any of these things, then you were engaging in solidarity between generations. So this is what I mean about it being everywhere. And this solidarity between people of different ages, it's been a mainstay of human societies for as long as we can remember. And this is why social policy scholars like me study in detail how it translates from the individual level to community level to national level through the welfare state and even up to international level. At national level, the welfare state is funded by taxes and social insurance that workers are paying, and this funds the schools and pensions of younger and older people. And they do this because they benefited from other generations paying for their education when they were younger. And they know that their pensions will be funded by people who may not even have been born yet. Internationally, we have young environmental activists like Greta Thunberg, who are fighting for the rights of future generations just to have an earth to live on. The reason I want to bring this solidarity between generations to your attention in the context of the current pandemic is because I studied solidarity between generations in a previous crisis, and I believe that it could play an important role in the aftermath of the COVID-19 pandemic. I was involved in a study of solidarity between generations in Ireland in the aftermath of the 2008 economic crisis, when Ireland was paying the price of a flagrant economic policy with one of the harshest austerity programmes in Europe. We found that in times of greatest hardship, people came together across the generations. I will never forget interviewing a retired bank manager who was paying the mortgages of 2 of his children in their entirety because they had lost their jobs. The solidarity we found was genuine. It was not temporary or convenient. It was so deeply part of the social worlds of family and community that for much of the time it went unnoticed. In the end, we concluded that it was the main reason Ireland's austerity programme passed without major civil unrest. At the moment, we're experiencing the flip side of solidarity between generations. Generational solidarity is the reason why we're finding the lockdown so hard. To keep children away from their grandparents, to avoid our siblings, to give our local football club a wide berth, it goes against our natural instinct. This is why solidarity between generations must be a central part of society's recovery from COVID-19. We must use this ability to make sacrifices on behalf of others to build support for a stronger health system, fair and decent social care for people with disabilities, a range of educational initiatives to help children and young people catch up on the schooling they've missed. When the lockdown is finally lifted, when you're at last allowed to hug your grandchildren or have a drink with your dad, remember this. Remember this period of generational isolation. Remember how odd it felt to live without other generations. Remember how much we can and should rely on solidarity between generations to build a more stable, secure and sustainable future for everyone.
Hello, I'm Professor Stuart Elborn. I'm Professor of Medicine at Queen's University Belfast. I'm Pro-Vice-Chancellor for Medicine, Health and Life Sciences. Science is based on uncertainty. This notion is interwoven in physical and life sciences and sits at the centre of hypothesis testing. Scientific experiments and research seek through testing hypotheses to challenge assumptions and therefore increase the certainty in how we interpret data and other information that comes from the biological and physical world around us. All science has uncertainty. Unless that uncertainty is communicated effectively and understood, decision makers may put too much or too little faith in it. Firstly, I want to discuss a couple of things that are really pretty certain. The SARS-CoV-2 virus, which causes COVID-19, has the features we associate in general with many viruses in the world. Viruses can exist outside of a host as a viron, but cannot reproduce independent of a host, which could be a plant or indeed an animal. The second thing that's certain is that viruses can't think. They have a very modest amount of nucleic acid, which they use in host cells to reproduce. During this current pandemic, the SARS-CoV-2 virus has been described in a multiple of ways that suggest it has intent. But this virus is neither evil, sly, or nasty. And we are not in a war against this virus because it is simply behaving as viruses do in this context. The final certainty I want to just mention is that this is not the first pandemic to affect the world, nor will it be the last. So back to basics, everything we measure has a degree of uncertainty around that measurement. So any physical measurement has essentially two components: a numerical value, which is usually specified in a system of units, which gives the best estimate possible of the quantity being measured. And then secondly, a degree of uncertainty associated with its estimated value. Uncertainty is often expressed as a range of values around the value that has been measured. Sometimes these are called confidence intervals. So let's think about the COVID-19 pandemic and take, for example, the R number. So the R number, sometimes pronounced as R0, is a mathematical term that indicates how contagious an infectious disease is. If R0 is less than 1, each existing infection causes less than one new infection. In this case, the disease will decline and eventually die out. If R0 equals 1, each existing infection causes one new infection. The disease will be alive and stable, but there won't be an outbreak or an epidemic. If R is more than 1, each existing infection causes more than one new infection. The disease will be transmitted between people, and there may be an outbreak or an epidemic. Importantly, a disease's R0 value only applies when everyone in the population is completely vulnerable to the disease. This means no one has been vaccinated and no one has had the disease before, and there's no way to control the disease. So R0 is a measure of disease potential, and once response measures are put in place, such as screening, quarantine for example, the actual transmission can be lowered. The actual or effective version of the reproductive number, as opposed to the basic version, is known as RT. That is the viral's actual transmission rate at a given time. This value has a major focus from our scientists trying to measure or derive it, and from our policymakers and politicians to help with decision making. The RT number is calculated using age-stratified regional transmission models. So for this critical number, there are assumptions in the model used to calculate it, and there's also measurement error from the numbers going into the model. I'm really just using this as an example of a key measurement which is driving decision making nationally and regionally, but must be used with an understanding of the level of uncertainty that is appropriate to this particular value. This leads to both mathematical and societal uncertainty and can be very disconcerting. The scientific estimates, despite their uncertainty, however, provide a really helpful guide for decision making, which then can be modified depending on the real world outcome. This will require two things from society. Firstly, that we understand the uncertainty of the science. But secondly, we need to appreciate that the science has been extraordinarily helpful in the decision making so far, particularly around how models and predictions have helped us manage the initial phase of this pandemic, where the NHS was not overwhelmed because significant increases in intensive care beds, ventilators, and availability of hospital beds had been delivered. We do need to learn to continue to live with questioning minds, to deal with future challenges from nature, which may result in further pandemics or other natural and physical consequences of the dominance of human beings on this planet. This pandemic should teach us that we need to understand these uncertainties across the globe and be humble and collaborative in our approach to containing them. We need to figure out, as a species, how to live in a healthy and balanced ecosystem where we respect, support and work collaboratively with each other as human beings and have the respect and stewardship over the diversity of the natural resources that we have on the planet. Thank you.
Coping with a different way of life is not the only challenge that we're facing right now. The global pandemic that is COVID-19 has challenged our way of death as well, in a way that we would not have thought possible just a few short months ago. As mortality rates climb worldwide, what happens to the bodies of those who have died has become a pressing issue and something that governments have had to deal with. And we've seen striking examples of this in the way in which emergency laws and lockdown restrictions have impacted on funerals. The law's treatment of the dead has always been based on two things: the notion of respect for the dead and protecting public health. The first of these things, of course, speaks to basic notions of human decency and dignity. The second one is always about the threat of disease from decomposing bodies. But when we have pandemics like we have now, the balance very much shifts towards public health. If we think about the messaging around COVID-19, we're told to wash our hands, to practice social distancing, to self-isolate. The public health image of that is clear. The dead are not immune from that public health message either. Dead bodies tend to be thought of now as being contaminants. There are strict protocols in place for how we handle the bodies of COVID-19 victims. For example, funeral directors have to wear protective clothing. The dead are placed in closed coffins. But it's not just the risk of virus transmission from the dead that we have to be alert to. There's a risk of transmission of the virus amongst the living when they come together to mourn the dead. And that's something that's driving the restrictions on funerals. And this seems to be a very real threat. We saw an example in April of 6 people who died of COVID-19 after coming together at the same funeral in South Carolina. So funerals are still being allowed to go ahead under lockdown provisions. We see examples of this happening all the time, and funeral directing is classed as being an emergency service or an essential service under the lockdown restrictions. Governments worldwide are really trying to strike a delicate balance. They're trying to curb the transmission of the disease. They're trying to ensure that cemeteries and crematoria do not become overwhelmed as death rates climb, and unfortunately we have seen examples of this in Italy a few weeks back. And they're also trying to ensure that the living are able to bury or cremate their dead. When we think about funerals do a lot more than just removing bodies from the realm of the living and negating the public health risk. Funerals are important social rituals. They allow people to come together to remember the person who has died, families and friends to comfort each other to mourn the loss, and to derive societal support from members of the community who will also attend the funeral. But COVID-19 is making us behave very, very differently at those funerals and changing the format of funerals. It's a way in which the law is impacting on the social rights and the traditions of funerals in a way that we wouldn't have thought possible. When we think about the social distancing restrictions, the restrictions on movement, we see all that impacting on funerals. A lot of countries have imposed numbers limits. For example, Spain decided to limit attendance at funerals to 5 people. France was initially talking about limits of 20 people. Ireland opted for a maximum of 10. The UK government didn't impose a numbers restriction, but it said that funeral attendance should be limited to members of the same household and immediate family. Of course, whether you look at numbers or a marker based on whose immediate family, the basic question is still the same. At a time when families are emotionally distraught, who decides who goes to the funeral and who doesn't? Small numbers, of course, make social distancing a lot easier at funerals. And that's just not to protect those who are mourning the dead, but to protect funeral directors, celebrants, cemetery and crematoria workers, those elements of the death care industry who are providing such a vital service right now. The public health narrative is a strong one, of course. But we should bear in mind that when governments are talking about protecting public health, what they're really talking about is protecting physical health. There are bigger issues, I think, around mental health and the emotional well-being of the bereaved. And this is something that both grief counsellors and bereavement charities have acknowledged already. The horrendous impact that these altered funeral rituals are having on those who have lost loved ones during the pandemic. For families, there's no chance to say a proper goodbye. A loved one who perhaps died alone in a hospital or a care home is placed in a sealed coffin. Families don't get a final chance to view the dead. There's also the fact that the basic social rituals around funerals, the holding of a wake, the shaking of hands, the comforting hug, those have all been stripped away by COVID-19 protocols and the restrictions that are being placed now on funerals. Of course, some adaptations have been made. What we're seeing now during the pandemic is a huge increase in live streaming of funerals. Again, it's another example of how technology is allowing us to stay together when legal restrictions force us apart. But for many people, it does help a little, but it's not the same thing as being physically present at someone's funeral and being able to say a proper goodbye in person. A few final thoughts then. Where are we now and what might happen in the future? Well, obviously, every society prides itself on how it deals with its dead and how it treats its dead. But unfortunately, funerals are yet another one of our social rituals that we've regrettably but necessarily had to amend significantly during COVID-19. Governments are advising us and warning us that social distancing rules are going to be around for quite some time. And even as lockdown restrictions ease, I don't think we're going to see funerals returning to normal straight away. We've already seen it in New Zealand. New Zealand was quite widely praised for how it dealt with its pandemic and curbing the spread of the disease, keeping numbers under control and low number of deaths. But when it started to move out of its lockdown restrictions on the 11th of May, the government announced very quickly that funerals would still be limited to no more than 10 people. The reason, they said, funerals pose a huge public health risk. Family and close friends of the deceased will come together. They will want to hug and comfort each other, and that threatens disease transmission again. We have to accept, I think, that it may be months, maybe even years before funerals return to some semblance of normality. I don't subscribe, however, to the view, as some people have suggested, that COVID-19 funerals will become the new norm, that we'll see much smaller numbers of people going to funerals. Coming together in the communal rituals around funerals are part of our social fabric. They're part of our socio-cultural DNA. And I think they're another social ritual that we will readily embrace again once we've moved beyond living and dying in the shadow of COVID-19.
In these modern times, we're growing increasingly used to healthcare advances happening at lightning speed, and that's thanks to world-leading researchers across the globe, including at Queen's University Belfast. However, the recent coronavirus crisis has really highlighted how much time, effort, energy and expertise goes into identifying and developing cures and, importantly, vaccines for these particularly virulent pathogens and diseases. Of course, whilst we're waiting on the development of a cure and a vaccine, and as things stand at the minute that could be at least a year or more away, we've been issued with guidance both at a government and local level that's aimed at helping us to remain safe and to reduce the spread of this very dangerous infection. Of course, as time's moved on, we've seen the modification, relaxation and in some countries removal of that guidance, including lockdown measures. And at this point in time, we're not 100% sure of the effect that will have on the infection and mortality rate related to this disease. Throughout this crisis and the various different types of guidance that we've been given, however, one piece of guidance has remained consistent: to ensure that you regularly, thoroughly and correctly wash your hands with soap and water. And this guidance seems quite simple and straightforward. How can simple soap and water help to defeat this virus and to keep our population safe? To start to think about this a little bit more, it's going to be important to think about what soap is and how it actually works before we start to think about it in the context of the coronavirus. In chemistry, we refer to soap molecules as being surfactants or surface active agents. And whilst this sounds like quite a complicated term, all it really means is that soap and surfactants can really have a major effect in terms of how different things stick to one another, how their surfaces interact. And that's of course the basis of how soap helps us to do things like clean our skin and things within the likes of our kitchens and bathrooms as well. To understand that a little bit more, it's important to look at the structure of soap or a surfactant, because that will help us to understand the basis of how these particular substances work. Here we can see a very straightforward representation of a surfactant molecule structure, and what we can see here is that there are two main parts to the molecule. A hydrophilic head that really likes interacting with water, and a hydrophobic tail that really doesn't like water at all. So if we start to put these surfactants into some water, they will try and arrange themselves so that they're as happy as possible, with the bits that like water being in contact with it, and the bits that don't being as far away from it as possible. So let's think about trying to clean something with soap. We have some dirt on a surface in water, and we add some soap to that situation. What happens over time is that the hydrophobic tails want to get away from water, and they form what we call micelles. And micelles are essentially little bubbles of surfactant that have all of the hydrophobic tails pointing inwards so that they're as far away from the water as possible, with the hydrophilic heads pointing outwards in contact with the water. When we do this in reality and we're cleaning something like our hands, for example, pieces of dirt will be trapped within these micelles, and that means that these pieces of dirt are trapped within these bubbles that have an outer layer that likes being in contact with water. And as such, as we continue to wash our hands, for example, those pieces of dirt are carried away by the flow of the water over our hands.
So now that we understand a little bit more about how soap works, let's start to think about the coronavirus itself, have a look at its biochemical structure, find out more about how it works, and in doing so, we'll get a really big clue about how soap can help us to defeat this infection.
The SARS-CoV-2 virus, which is the cause of COVID-19, shares its structure with a range of other viruses. The simplified structure that we can see here shows two main areas within the virus's structure. One of these, the lipid bilayer, is the most important part in terms of how soap can be used to defeat this virus. And this lipid bilayer is made of molecules that are very similar to those that we've seen already. Molecules that contain a hydrophilic head that likes water, and hydrophobic tails that really don't like water much at all. In the case of this virus, these molecules arrange themselves in this double or bilayer, with the hydrophobic tails facing in and the hydrophilic heads facing out into water. As a result, we end up with this thick layer, the middle of which is hydrophobic and contains very little water, and the outside of the virus then coming into contact with water as a result of those hydrophilic heads. If we then introduce water and our soap into the system then, we know that our soap, our surfactant molecules, have those hydrophobic tails, and they're constantly searching for an area that contains very little water. Luckily for us, we know that the inside, the innermost part of this lipid bilayer is hydrophobic and contains very little water. And as we continue to wash our hands and use soap, the surfactant molecules try to locate their hydrophobic tails into this area that contains very little water. As the process continues, our surfactant molecules will do their job and continue to form micelles, as we've seen before. This time, rather than the micelles circling around a piece of dirt that might be on our skin, they circle around a certain number of molecules within the lipid bilayer, within the viral coat. As the process continues then, the micelle is carried away by the action of the water that we're using to wash our hands, and that leaves a gap in that lipid bilayer. That of course is a problem for the virus because it's got a massive hole in its surface now, a lot like popping a balloon, and that then allows very important processes to occur, like the removal of the viral's replication machinery. That then means that our virus particle is no longer viable, can no longer replicate, and no longer cause the disease and the symptoms that we're all very aware of. So that's how soap can help us to defeat the coronavirus. In recent times, we've seen a lot and heard a lot about the use of hand sanitizer as well, even hearing stories of people stockpiling supplies to ensure that they have enough to last them throughout this entire crisis. Hand sanitizer is, of course, very effective, but it misses out a few of the key important points that soap and water provides us. One of the main ones being the action of the soap and the water together to carry away all of those pathogens and the particular particles that they break up into, away from our skin and down into the drain. And that's a very critical and important point. So what does this all mean for us then? We should ensure that we continue to wash our hands correctly, thoroughly, and often. And when we can't do that, to make sure that we use a product like a hand sanitizer to try and minimise the amount of the virus that we're exposed to, reduce the spread, and keep everyone safe.
A key question within the field of mental health sciences is how are we going to cope with and adapt to the likely mental health impact of COVID-19 upon the population. The mental health community have mobilised with an incredible speed and efficiency to ensure that the support that's required currently is available. But they've also mobilised to ensure that appropriate data collection methods are underway. Several position papers have been published which outline what the research priorities are in this space now and into the future. It's really important for us as a mental health community to understand exactly the impact that COVID-19 is having on the mental health of the population, but also to understand exactly who needs the support, in what circumstances, and what type of support is required, and then of course if that support is fit for purpose. So my lab studied the field of psychotraumatology. This is essentially the study of stressful, adverse or traumatic life experiences on the mental health of people within the population. Therefore, it stands to reason that we're really interested in the impact that COVID-19 is having on the mental health of the UK population. So on March 23rd, we launched the COVID-19 Psychological Wellbeing Study across the 4 nations of the UK. This launch coincided with the day that the UK Prime Minister announced that every person in the UK should stay at home unless they had a very specific or essential reason to leave. So essentially this was the first official day of the UK lockdown. There is prior evidence that when restrictions such as quarantine and social isolation are put into place, that this does indeed impact on people's mental health and well-being. So to date in our COVID-19 Psychological Wellbeing Study, we've collected data from over 2,500 people living within the UK. Several hundred people continue to complete assessments on a weekly or monthly basis. So the question is, well, what are we doing with this data now that we have it? Well, myself and my team are based here in Northern Ireland, and therefore we felt it was important to interrogate the 470 responses that we received also from people living in Northern Ireland. So far we've concluded from the data that 30% of those responding to our survey are reporting symptoms that would be indicative of a generalised anxiety disorder. 33% of those responding to our survey are reporting symptoms that indicate a major depressive disorder, and 20% are reporting symptoms that indicate a post-traumatic stress disorder. Now, it's important when you have figures like this that you're able to make some comparisons. So we can go to the Northern Ireland Study for Health and Stress, which was a population-wide survey conducted between 2004 and 2008. They also produced some figures around these common mental health disorders, and they reported that in Northern Ireland, 4.4% of the population met the criteria for generalised anxiety disorder, 16.3% met the criteria for major depressive disorder, and 8.8% met the criteria for post-traumatic stress disorder. Now, it's really difficult that we make comparisons across studies or that we make direct comparisons. And this is because sometimes we use different measures of people's psychological symptoms, or we might ask people to report their symptoms across a different time span. So the Northern Ireland Study for Health and Stress reported symptoms across people's lifetime, whereas in our study we asked people to report their symptoms across the past 2 weeks or the past month. So you can see how some comparisons might be difficult. There is some work going on in the UK related to COVID-19 psychological well-being, a similar study to our own. And this study has reported that of all of their respondents across the UK, approximately 22% of them were reporting symptoms that indicated a generalised anxiety disorder or a major depressive disorder. And in that study, approximately 17% of their population were reporting symptoms that would indicate a post-traumatic stress disorder. So you can see that there's similar results coming out from these studies. But the good thing about the work that we do is that we can also collect information about socio-demographics. So we can look at what particular factors or particular demographics might predict who will or who won't have one of these mental health outcomes. So we found a general trend in our data based in Northern Ireland, whereby vulnerability for mental health outcomes was indicated by being younger aged, by people who had a pre-existing mental health condition, those who were engaging at a very high rate with social and traditional media, and also those who were really concerned about being infected by COVID-19. We also found that those who were employed in one of the key worker roles as assigned by the government were more likely to have a mental health outcome than those who were not. So now that we have this information, it's really important that we use it to actually help people with mental health across the population. And therefore we need to use it to improve the outreach of services. So we need to ensure that outreach of services meets the needs of those people who need them. And therefore we need to ensure that we try to get services to hard to reach populations. We also need to prioritise the evaluation of therapeutic interventions that are available to treat these common mental health issues. And also we need to look at how effective these are when they're delivered on digital platforms. The government officials should look at funding plans for the enhancement of the mental health workforce. And indeed, the Department of Health in Northern Ireland just launched a mental health action plan containing 38 action points. But it's really important that to ensure that we cope with and adapt from the mental health impact of COVID-19, that the mental health strategy in Northern Ireland is well coordinated, well resourced, addresses those in hard to reach groups and ensures appropriate workforce planning to ease the pressure on mental health workers.
On Sunday the 29th of March, I lost my uncle to COVID-19, a virus that no one had even heard of just 6 months ago. A few days later, my colleague Edward Vidoliak, while consoling me on my loss, also shared with me his worrying concern in relation to citizens and patients in his native Croatia, many of whom were not attending their doctors for fear of getting a COVID-19 diagnosis rather than a cancer one. This concern in relation to COVID-19 being more serious than cancer, I've also heard anecdotally from colleagues in the UK, in other European countries, and in the US. With over 30 years' experience across the cancer spectrum, I am regrettably only all too familiar with the negative impact that cancer can have on patients, their families, and their carers. However, this COVID-19 pandemic is introducing a new reality, compromising our normal way of life and having significant effects on our society's health and well-being. The number of deaths attributable to COVID-19 in the UK is extremely concerning, having now passed 40,000. But it is worth remembering that over 165,000 people die from cancer every single year in the United Kingdom. One aspect of the current emergency that really worried Edward and myself, and also my friend and colleague Richard Sullivan in King's College London, was the realisation that government-backed national lockdowns could have the unintended but very profound consequence of impacting negatively on cancer services and on cancer outcomes globally. We voiced our concerns in an opinion piece that appeared in the European Journal of Cancer. We highlighted how the understandable focus on repurposing a health service towards the COVID-19 pandemic could have an unintended effect of compromising national cancer screening programs, of delaying cancer diagnoses, and of cancelling or postponing cancer treatments. The net result? Significant increases in cancer mortality and cancer-associated health problems locally, nationally, and globally. On Wednesday, the 29th of April, exactly 1 month after my uncle passed away, I, with colleagues at University College London and DataCan, the UK's health data research hub for cancer, posted a scientific paper online reporting the results of a large and very significant research study. We presented robust evidence that showed that the concerns that we highlighted in our opinion piece were not unwarranted. We employed real-time data from major centres in Leeds, in London and in Northern Ireland to show that unequivocally we were seeing differences from the pre-COVID-19 days. Urgent referral rates, that's really our early warning system or red flag for catching cancer at its earliest stage, had plummeted by 76%, while patient attendances at chemotherapy clinics, which is really a good proxy measure of a cancer service's health, had dropped by 60% compared to pre-COVID-19 levels. Furthermore, in our analysis of over 3.8 million health records from patients in England, the largest study that's ever been performed, we estimated that the COVID-19 pandemic could be causing at least 6,300 excess deaths in patients with cancer. And this is a conservative estimate because it's only relevant to newly diagnosed cancer cases. If we extrapolated to new and existing patients living with a diagnosis of cancer in England, our estimate could rise to nearly 18,000 excess deaths, which is an extremely concerning number. And it's not only in England that we see these dramatic increases. We performed a similar analysis in data from the US, where we estimate between 20 and 30,000 excess deaths, a significant increase on the US annual death rate from cancer for those diagnosed in the current year. What is particularly revealing about our study is that nearly 8 out of 10 of those patients with cancer also have another underlying health condition. These comorbidities, as we term them, many of which we could control through already available medicines, include heart disease, hypertension, obesity, and diabetes. Diseases that could be managed either through medicines or through self-management. Despite these challenges that I've outlined, I must encourage cancer patients or citizens who are worried that they may have the symptoms of cancer to continue to access their health services. Critically, however, governments must ensure that those health services are fit for purpose. Responding to a question posed by the media based on our work, Prime Minister Boris Johnson, in his first daily press briefing since returning to good health after his COVID-19 hospitalisation, highlighted the need to deliver cancer services to our citizens. I cannot emphasise how important this is, but it must be for all of our citizens and it must be delivered as soon as is possible. I hope that our work can inform the critical second phase of the National Health Service's response to the emergency, particularly by resuming cancer services at pre-COVID-19 levels. While welcoming Prime Minister Johnson's promise, our results are very concerning. We believe that countries across the world need to take heed of our warning. Otherwise, we risk adding cancer to the escalating death toll of the COVID-19 pandemic. We must recognise that people with cancer, especially those with comorbidities, those additional health conditions need to be considered as an extremely vulnerable group of patients, and their care must be managed appropriately, effectively, but most importantly, in a timely fashion. Our governments have to ensure that health services maximise access to real-time data like we have provided, so that we can determine which comorbid disease combinations pose the greatest risk to our patients and which COVID-19 induced changes in our health systems are rapidly compromising the health and the well-being of patients with cancer. Cancer intelligence is critical for our cancer patients, both now, but even more crucially in the COVID-19 recovery phase. Data can really save lives, but only if we get these data quickly and use them intelligently. I've been privileged to have worked in cancer for the last 30 years, when we have made enormous progress in our fight against this killer disease, particularly here in the United Kingdom. It is important that we don't allow the great work that we've done over the last 30 years to be undone in the next 3 to 6 months. We must act now, and I mean now. Otherwise, we risk the unintended consequence of a COVID-19 pandemic precipitating a future cancer epidemic. And nobody, but nobody, wants that.
Over the past number of weeks, all of us have had to adapt and change everything that we do, limiting our contact with people, being scrupulous about washing our hands, standing patiently in line to enter a supermarket, and staying at home. The word home has become loaded with meaning. For many of us, home is a place of safety and sanctuary, but this is not the case for everyone. What has become very apparent over the past few weeks is that care homes for older people have not been places of safety either for staff or for residents. The care home setting has been the forgotten frontline in the UK. Numbers of cases and deaths in UK care homes were not reported in the early stages of the pandemic, and it is only now that we're beginning to understand the scale and the impact that the coronavirus has had in this environment. Many who, like me, who've conducted research in care homes and are familiar with the sector, are sadly not surprised by what has happened. So why has it happened? And what lessons can be learned from this tragedy? Care homes, which is a term sometimes used to describe nursing or residential homes, provide care usually to older people who are unable to continue to live in their own homes. The average age of residents is around 80 years. The population is largely women, about 70%, and most will have 2 or 3 medical conditions, including dementia. This means that they will be taking a number of medications, and in some cases more than 10. Care home residents tend to be more prone to infection, and research that we did in Northern Ireland in 2011 showed that there were higher levels of antibiotic prescribing used to treat infections in Northern Ireland nursing homes compared to homes in other European countries. Another study, which we published in 2010, found high levels of a bacteria called MRSA in both residents and staff. Further research showed that controlling infection in care homes was difficult for staff because of lack of time, and they didn't have the resources to purchase the necessary equipment to prevent infection. A survey conducted by Mather Lifeways, which provides care services to older people in US nursing homes, found that staff felt ill-prepared to deal with public health emergencies. In the UK context, care homes are not seen as part of the National Health Service. Many of them are privately owned, and this may affect access to personal protective equipment, PPE. And importantly, as the name suggests, care homes are homes. They are the residents' homes, albeit on a communal basis, and staff will try to enhance that homely environment rather than create a clinical environment which would be commonly seen in a hospital. So all of this background highlights how a perfect storm has been created in care homes during this pandemic. A vulnerable population, a high-risk environment, and lack of resources. But perhaps there's also been an intangible factor at play, and something the society may not have been prepared to admit. Do we really care about what happens in care homes? The residents are old and are probably going to die anyway. So why bother to test, and why bother to count the number of cases and deaths? Prime Minister Boris Johnston stated in the UK Parliament on Wednesday, May the 6th, "There is an epidemic going on in care homes, which is something I bitterly regret. There's been growing recognition that care homes were left behind and forgotten in the early stages, and there's now a concerted effort to play catch-up with testing, the provision of PPE and further support from the NHS, with hospital nurses now working in care homes and other staff providing advice on infection control. Care home staff have worked under the most difficult of circumstances to provide the best care to residents, to the extent that many are now living on site to maintain lockdown conditions and minimise the risk of transmission. As we move towards a possible lifting of some of the more extreme elements of lockdown, might the experience witnessed in care homes lead to a more sustained and permanent change in how society views older people, and particularly those who reside in care homes? Might care homes be seen as an important part of health and social care, not sitting at the periphery of the NHS and often viewed as the care provider of last resort? In 2007, the British journalist Polly Toynbee wrote in an opinion piece for The Guardian, "Schools are hot politics, old folks' homes aren't." 13 years later in 2020, care homes have become hot politics, but for all the wrong reasons, and society has been appalled at what has happened. But perhaps this tragedy will be the catalyst for change in care homes. On a Thursday night, we stand on our doorsteps to applaud those working in the NHS and other frontline workers. Let us reflect, in particular, about care homes, the staff, the residents, and what they have faced over the course of this pandemic. It is timely that we think about what we value, and when it comes to the care and protection of some of the most vulnerable in society. And we should think about what we would want for ourselves if, in the future, we become care home residents. Alan Bennett, the writer and playwright, has been an advocate for improving care for older people. He has written movingly about his own mother's time in a care home where she eventually died. In his book, Telling Tales, he reminds us that old age will come to many of us despite what we think. He writes the following: "And one of the ways the young think they are safeguarded against the fate and the future of their grandparents is by their names. Sharon's don't suffer from dementia or Damien's from incontinence." Alan Bennett goes on to warn us that our names are not enough to save us. I quote, "But coming up the road are the Deans and the Darrens and the Waynes, and they too shall fail. It won't be long before even Tiffany is a grandmother and her cot got ready in the corner. Her children, middle-aged and vaguely resentful, come and sit with her on Sunday afternoons while she tries to remember who they are and who she is. You're Tiffany, mother, and this is your little granddaughter. And what will her name be?"
When the university, along with the rest of the UK, went into lockdown, my immediate response was to place the School of Mechanical and Aerospace Engineering, its expertise and resources, at the service of the NHS and COVID-19 frontline workers. How could we best make a contribution? Now, we could have made a small contribution being part of a design team or a supply chain for ventilators, or address the immediate need for personal protective equipment. Timing was of the essence. How could we best maximize impact in minimum time? Our frontline workers were in immediate need of face shields, and while there was a quick response from various volunteers to start manufacturing these using 3D printers, we opted for a faster method of production using laser cutting of flat polymer sheeting. And there are also certain shortcomings with 3D printed visors which could be mitigated using our approach. Of course, we could have considered injection molding or other types of manufacturing, but each entailed delays in getting to production. By utilizing the resources within our prototyping laboratory and the Polymer Processing Research Center that sits within the school, we were able to quickly develop a number of prototypes, which we then shared with senior medical staff for feedback. And the design that emerged was a lightweight yet robust face shield, which used different polymers. So for example, we used acrylic for the brim, we had polyethylene for the adjustable headbands, polyethylene terephthalate for the visor itself, and polyvinyl foam. And the choice was very much a balance between design requirements and material availability. It also had to meet certain standards addressing things such as field of vision, comfort, safety, and optical clarity. In field testing, certain features were particularly welcomed. The use of a transparent brim, for example, which allowed light through and did not cast a shadow over the eyes, like some of the 3D printed ones, which make use of opaque polymers, or even the thick foam used on disposable NHS-issued face shields. The brim also had no holes, so there was no possibility of downward aerosol reaching the eyes, and the shield itself was a good distance away from the face to comfortably accommodate an FFP3 mask. The headband also gave the face shield additional stability, which meant that the elastic around the head did not need to be tied so tightly, which added to the comfort over extended use. And the corners were also brought in to allow some sideways head movement. Now, I mention all this because through the feedback that we're able to get quickly, we were able to go into production 48 hours from initial concept. And since that time, we've delivered thousands to hospitals, nursing homes, St. John's Ambulance, and other places. And they've proved very popular. Indeed, when provisions from the NHS started arriving in hospital stores, medical staff asked us to continue providing their teams in preference of the standard issue. But to me, beyond doing my small bit to help, what was equally satisfying was the experience that this has provided in motivating staff whom I called upon to help realise this project. When we went into lockdown, I asked my technical staff whether they would be willing to assemble these shields. And within a few hours, my chief lab technician, who was also my health and safety coordinator, had set up socially distanced, fully equipped assembly and disinfecting stations, and also organised rosters for those technical staff who were in a position to help. Their enthusiasm and willingness to help was heartfelt and sincere. And I was reminded of Daniel Ping's book Drive, where he observed that the most deeply motivated people, not to mention those who are most productive, hitch their desires to a cause larger than themselves. And it ties in with what I've always tried to do within the school, adopting Simon Sinek's mantra, if I may call it such, of starting with why in everything that we do. I also made it a ritual to share every bit of positive feedback that we were receiving from grateful NHS staff with the rest of the team. It was an opportunity for me to also interact with staff within my organisation at a frequency and level which my day-to-day job does not often allow. And as this project became a sizable operation, other volunteers followed, including a research project manager who started handling requests and prioritising distribution, and my school's production manager, who was ever willing to update CAD drawings at short notice as we tweaked the design here and there, and then posted them on social media for others to use freely. So, how may we emerge as a school once this pandemic is over? Well, there's certainly a wider piece to consider around higher education in general, but from my perspective, as a head of a research-intensive school with degree programs in aerospace, mechanical, and production design engineering, how might this experience change what we do, and more importantly, how we interact with each other? Will my risk register now include such unlikely yet plausible events, and have in place an agile and responsive design and manufacturing capability to deal with whatever may be required, perhaps even linked with the rest of the UK and Ireland? Indeed, we have just embarked on the design of an intubation shield at the request of medical surgeons. Now, will my academic staff find new inspiration in their research and teaching endeavours? And how can I and the school management team provide opportunities for all staff to further enhance their sense of purpose and to pursue heuristic work? Time will tell. But above all, I hope to tap into the intrinsic motivation that has driven this face shield team to excel. And who knows, perhaps this will lead to a level of collegiality, understanding and concern for each other's well-being that will result in an even better place than the one we left behind at the start of lockdown. Thank you.
Hello. The research and teaching project that I manage as a lecturer in architecture at Queen's University is the Street Space Project, which investigates the complexity and value of local mixed streets. The project works in collaboration with people of different backgrounds, such as academics, students, practitioners, and policymakers, to explore the value of streets as essential public spaces. Today, I will discuss some of the changes to streets that we're beginning to see brought about by the COVID-19 pandemic. Obviously, this is a dreadful phenomenon. The pandemic is affecting every country in the world in terms of health, economy, and well-being. But in these uncertain times, we may be glimpsing the emergence of trends that might start to reshape streets as we know them. Many cities around the world are redistributing the space of streets to allow for social distancing. Milan, Paris, Toronto, and many others are currently widening footpaths using temporary infrastructure to provide space for distancing. Other cities, like Rome, are taking this further and are already building permanent infrastructure to provide more space for active commuting once the lockdowns are lifted, but people still need to social distance. Now, this is not really a new development. The virus is actually acting as a catalyst. Since the car began to take over cities all across the world after World War II, there have been movements to resist this. Large infrastructures were developed inside and outside cities to enable the car to be the main means of transport to get around. Much of the development done to facilitate vehicle traffic damaged the space that pedestrians and cyclists used to share. Increasingly, since the 1960s, activist groups have protested against car-centred development, but with little success on the ground. A few exceptional cities, such as Copenhagen, Amsterdam, and Vienna, developed rich, segregating cycling infrastructure and regulations, which have enabled them to be some of the most desirable cities to live in the 21st century, as published in the ECA International and Mercer rankings. More recently, to address problems with pollution, air quality, and road safety, other cities are pushing for the development of more diverse modes of transport, focusing on pedestrians and cyclists. Anne Hidalgo, while mayor of Paris, made the bold move in 2017 of banning traffic from the Seine motorway in the centre of the city, in a 6-month temporary plan that became permanent. Janet Sadiq-Khan, while commissioner in the New York City Department of Transportation, through a project in collaboration with Gale Architects, pedestrianized Times Square and transformed it. Ada Colau, current mayor of Barcelona, is working on a project to remove through traffic from 2/3 of one district's streets, the Eixample, through the Supercuadras. Cities all over South America, like Buenos Aires since the early 2000s, are now prioritizing walking and cycling and public transport above individual cars. Belfast and other Northern Irish cities were ripe for motorway development and car-centred street design in the 1960s. And despite some pockets of resistance, this type of development went largely unchallenged until the end of the 20th century. Many campaigners did demand better, healthier, and more accessible means of transport, but their calls have fallen on deaf ears for decades. Until now. The lockdown has shown people, including politicians, that streets with less vehicle traffic may enable a healthier, more livable environment, where noise, pollution, and road dangers are reduced. For example, in Belfast currently, In the midst of the COVID emergency, there are two potentially positive developments being considered in the city. The first development concerns the York Street interchange, a project with plans to widen the roads at this area to enable more cars to come into the city. This scheme is currently being reviewed afresh, which may mean that the area adjacent to it, left barren for decades, might potentially be developed back into the thriving neighbourhood the area called Sailortown once was. The second positive development is the 5th May announcement by Northern Ireland's Infrastructure Minister, Nicola Mallon, that a new walking and cycling champion for Northern Ireland is to be appointed. This presents a real hope that street design features called for over the last decade might finally be materialised, with more focus given to designing better cycle lanes and better walkways. From these examples of change that we're just starting to see coming through the street planning and design, I think we're witnessing more awareness of important role for street architecture and city planning as tools to improve the lives of city residents. Here's hoping that this new life that is in front of us might bring cleaner air, healthier streets, and a friendlier and calmer environment.
We have all had to change the way we work over the past few months due to COVID-19. As a geriatrician working in an acute hospital, my team and I saw huge changes implemented really quickly to our working practice. Multidisciplinary teams pulled together to get COVID-19 wards ready for our patients. Delivery of training on all aspects of care for our patients occurred at a rate never previously experienced. There was a great sense of camaraderie, mixed with apprehension about what the care for our patients would look like in practice. Data from other countries ahead of the pandemic, such as Italy and Spain, showed the prognosis for our usual cohort of frail elderly patients was shocking. We were psychologically prepared for a crisis, the potential rationing of ventilators, and the possibility of our hospitals running out of palliative care drugs. When we looked at reports from China, the USA, Italy, for example, we saw that older people and those with underlying health conditions did particularly badly if exposed to COVID-19. All of our patients are older, and most of them have several underlying health conditions such as hypertension, COPD, diabetes, heart disease. So the prognosis looked particularly poor for our patients. Many of our patients are also frail. This means they are less resilient and have depleted reserves. By definition, it also means that they have underlying health conditions. As we age, our immune system becomes less effective also, and this means that older people are more susceptible to developing infection in the first place, and if they do develop it, they're less able at fighting it effectively. This issue of reduced immunity is especially important when we consider coming out of lockdown. Many people over 70 are annoyed at being called older, when in fact they feel very fit and well. This issue of biological rather than chronological age is important, but reduced immunity also has to be factored into the equation. As a result of COVID-19, some of our practices in hospital have changed, and some of these have been beneficial. Any patient admitted with COVID-19 has an advanced care plan drawn up, and this is irregardless of age. We discuss with the patient what they would like to happen should they deteriorate on the ward. Would they like non-invasive ventilation? Would they like to be considered for ICU, etc.? We also discuss these wishes with their family if it is appropriate, and resuscitation wishes are also documented. The patient is then discussed with the multidisciplinary team and with the intensive care team if it is appropriate. These very formalised means of communication are an excellent way for the multidisciplinary team to know what the plan is for each exact patient on the ward, I hope that something like this can continue beyond the pandemic. The issue of frailty is also discussed on each patient. We document how frail a patient is according to the clinical frailty scale. This was devised by Rockwood et al. There is evidence that patients who are even just mildly frail, and these are these patients who need help with managing bills or managing medication, for example, do not do well in an ICU setting. With mortality rates of 50% in ICU, even in selected patients, we have to ensure that we are providing ICU admissions for patients who are most likely to benefit from it. An ICU admission is expensive, but it can also be very distressing. So the potential futility of ICU treatment needs also to be considered. Beyond COVID-19, I also hope that people consider their long-term wishes more readily and more openly with their families. This anticipatory or advanced care planning usually only occurs when a crisis point is reached, and usually in a hospital setting in an emergency. Many of our patients, however, have long-term underlying health conditions such as dementia, heart failure, cancer, etc. And many needless hospital admissions occur towards the end of a patient's life. We all have difficulty accepting our own mortality, but if people have more open and honest conversations about what they would like to happen towards the end of their life, maybe some of these admissions, which can be distressing for patients and their families, can be avoided. During this pandemic, care homes have been particularly hard hit, and care home deaths may outstrip hospital deaths, a fact we would have found very difficult to fathom before the stark reality hit. Many care home residents, however, are choosing to remain in their care home with COVID-19 rather than be admitted to an acute hospital setting. GPs, community geriatric teams and care home assistants have really stepped up to provide holistic, patient-centred care where the patient wants it. I also hope this can continue beyond the pandemic when it is appropriate. Thankfully, in Northern Ireland, we have not seen the hospital deaths we had been anticipating at all. Care homes have been particularly hard hit, as mentioned. Many patients in care homes, however, are reaching the end of their lives and have underlying health conditions such as dementia, frailty, etc. We have a duty to ensure that we provide the right treatment to the right patient at the right time and in the right place. And for many care home residents, this will mean good palliative care in their own home. I would suggest that good, well-planned palliative care is something that we should all strive for towards the end of our lives.
Hello everyone, my name's Tony Gallagher and I'm a Professor of Education at Queen's. A couple of weeks ago I appeared on the local BBC News talking about education problems arising from the lockdown. When one of my granddaughters saw me on the TV, she walked up to the TV and asked me a question, and she was mightily confused when I didn't answer. It turned out she got so used to talking to me via Zoom during the lockdown that she thought I was on Zoom again. It was a reminder, I suppose, of just how much has changed in such a short period of time and of how quickly we've adapted to it. And in the few minutes we have together, that's really what I want us all to think about. What has changed in this crisis? But more important, once we get through it, what should change? We know that a lot of things have changed in education. Teachers putting in place arrangements for remote learning almost overnight. Schools printing learning packs and finding ways to distribute these to pupils. The cancellation of public examinations and new arrangements being put in place for teachers to predict grades using existing information. A lot has changed for families as well. Over a quarter of workers have been furloughed from their jobs. Many more are doing their jobs remotely while juggling childcare responsibilities. And many have lost their jobs altogether. In an extraordinarily short period of time, our world has literally turned upside down. But we've seen some wonderful things happening in this period as well. There's a wonderful spirit of social solidarity as people look out for their elderly or sick neighbours, helping them with shopping, or as we say in Northern Ireland, getting their messages. Tens of thousands of people have stepped up as volunteers in all sorts of different roles. And the national treasure, otherwise known as the NHS, has really come into its own. We've also come to appreciate what we mean by an essential worker, from the doctors and nurses in the front lines of our hospitals, to the porters and cleaners and administrators and social workers and care workers who've thrown a wider circle of care around those who are ill and their families, to the farm workers and truck drivers and delivery drivers and supermarket checkout staff who are keeping our food supplies moving. But I was very struck one morning when I heard Padraig Ó Tuama on the BBC when he said that lockdown had proved to be a revelation. But not, he said, because it had shown us something new, but because it had revealed something to us that had been there all along. And what it had revealed to us was the depth of inequality that continues to poison our society and the limitations in our ability to tackle it. There's now plenty of evidence emerging that the education achievement gap between the affluent and the disadvantaged is getting wider by the day. Surveys have identified a pattern of differential access for and support, with children and young people from poor households losing out. In a survey carried out by Maynooth University into primary schools, one teacher graphically put it like this when she said, about a third of parents will ensure the prescribed work is done, another third will be overwhelmed and unable to engage with distance learning, and another third will just not bother. And day by day, our understanding of the scale of the problem grows. Special arrangements in England to support children entitled to free school meals only partially worked at the start, and weeks into lockdown, 30% were still not receiving a substitute. We're hearing more and more concern on mental health and stress effects from families being cooped up together. And there are growing concerns about the longer term impact of adverse childhood experiences arising during the crisis. The bottom line is that if a child is hungry, living in cramped conditions, with limited access to education materials, whose parents have limited confidence or capacity to help them, then the longer lockdown goes on, the more severe the impact on their educational opportunity. This is not the fault of teachers or schools, as their response to this crisis has been truly amazing. But for decades we've been living in a world where competition, marketisation and privatisation have been the drivers of policy, and efficiency has been the goal. Children and parents have been treated as consumers. Delivering value for money has become the holy grail of public services. And people have been encouraged to look out only for themselves. What this has produced is widening inequality. What it has produced are fragile public services focused on increasingly narrow performance targets. What we have lost sight of is the social role of education, the value of community, and the idea of the common good. And we have failed to support resilient institutions with the capacity to work with others to address and solve the complex, wicked problems that remain with us. And these problems and challenges affect every part of the education system. I consider myself lucky that I work in a university that's committed to making a positive impact on society. I consider myself lucky to work with teachers in Northern Ireland who, by their selfless dedication to the needs and interests of their pupils, have shown that the spirit of social solidarity remains alive and strong. All of these things give me hope, but we need to build on this hope to replace competition and selfishness with the spirit of compassion and cooperation. The world we build after the COVID-19 crisis cannot be the same as the one we have so recently left behind, mainly because the weaknesses and injustice of the old society have been laid bare by the crisis. Ken Robinson, noted educationalist and one of Queen's honorary graduates, recently asked whether we should look forward to restarting schools or resetting education. If we want to embrace the idea of education as a public good, working for the common good, in which every young person is given a fair opportunity, then a reset is really the only way forward.
Hello, my name's Ali Fitzgibbon and I'm a researcher at Queen's University Belfast, studying the cultural and creative industries. And in my work, I study the role of artists as workers in theatre, so looking at actors, directors and playwrights. In early April 2020, I began to work with a colleague here at Queen's, Dr. Yannis Soulakis, and we began to compare his work with musicians in Greece and my work in theatre in the UK and Ireland, to understand what was happening to these people in the wake of the massive restrictions being brought about by the outbreak of COVID-19. What we saw and continue to see is that there are very significant problems with how artists are being supported within the mass economic and social shutdowns brought about by the pandemic. There is very little government planning or thinking about how the performing arts and entertainment industries will be supported when they eventually reopen, and this is particularly the case for live events where there are mass gatherings of people. Because these industries are likely to be the last to reopen, we see a very real human crisis emerging for thousands of artists. This lack of attention suggests that artists are not being seen as real workers, or that the music and theatre that they create is not real work. And this reveals an underlying problem in how artists are valued in society, and particularly by governments. As in so many other areas, I can say that the pandemic did not cause all of the problems, but it exacerbated some long-standing underlying issues. In the performing arts, research for many years has pointed to problems of precarity, inequality as a result of gender, class, ethnicity and disability, problems of poor mental health, low-wage economy and unstable employment. This is particularly so for artists who earn less and are more precariously employed than other workers in the creative industries. COVID-19 has made this situation far, far worse. When governments in many countries began to introduce unprecedented levels of business support and employee furlough schemes, they were at first very slow to introduce supports for freelance and self-employed workers. Artists in turn struggled to get enough support from these schemes to earn a livable income. This is because portfolio working is commonplace among artists, so their income is drawn from multiple sources. Compounding this problem, all of their income sources, not just one but all, had disappeared overnight, not locally but globally. And because of their combination of taxed and freelance work, artists fell between the gaps of the different support schemes. In some countries, state agencies and government departments introduced artists' hardship funds, but many of these were on the basis with some expectation that the artists would produce something in order to access them. This did not consider the domestic circumstances of artists, their caring responsibilities, their health, or the digital inequalities we are all now coming to terms with. Nevertheless, despite some of these challenges, such was the demand that many of these funds have been overwhelmed, with some closing within days because they've simply run out of money. At the same time, the rush to get content online for free by artists and cultural organisations has been a critical form of social and cultural connections for many of the population. One must assume that there is some intrinsic social and cultural value in all of the concerts, performances, classes, choirs and other activities we have enjoyed online. Yet the individual artists who create these receive little or nothing in return, and many of them have no control over their artistic work in this digital space. One can also see the inequalities present in the live industry being replicated digitally. Those with the means and time to do so can perform online. Those without cannot. Put together, we can see that what existed before was unsustainable, and the pandemic has tipped it and artists over the edge. This raises important questions about how we as a society think of sustainability and fairness in the performing arts. More so, it makes us question whether there is any coherent thinking on how governments support artists right now, or how it will support the performing arts and entertainment industries as they emerge out of suspension in a radically altered state. What will emerge of the performing arts in a year, or 2 years, or longer, will not and cannot resemble its previous normal. Because of the underlying problems that predate where we are at now, and because of the long-term interruption brought about by COVID-19, we need to think in an essential and pragmatic way about how we deal with the present and prepare for the future. No one thing, but many things are needed to address the short-term and long-term changes we need. There is a moral obligation on every government right now to plug the gaps in the support schemes so that artists as workers, as carers, as people can afford to eat, to pay rent and stay safe. We need substantial reform of how government policy understands the value of artists and the wider cultural and entertainment industries. We need to radically rethink the performing arts ecology so that we address rather than repeat the inequalities of the past. In all of these conversations, artists have something to say. We need social welfare and wage reform to recognise how gig economy and freelance workers actually earn a living. And better still, we need health, social care, welfare and wage reform that recognises artists as citizens of value in our society. If we do not, then we have abandoned artists as our fellow workers, and future societies will be socially and culturally poorer as a result.
Hello, my name is John Barry. I'm Professor of Green Political Economy at Queen's University, Belfast. The pandemic has cancelled the future, but that's okay. It was a pretty bad one anyway. We should, as we're thinking about recovery from the pandemic, resist the calls to return back to normal. Normal was the problem. Normal was an ecocidal, unsustainable economic system based upon unsustainable globalization, creating more inequality in our societies, creating a less resilient food system, for example, as we're now discovering in the context of the pandemic. So I think we should think about building back better to see that as we come out of this crisis, we should see that we can deal with the public health issues around COVID-19, as well as dealing with other public health issues, such as improvements in air pollution around our cities, which we already see as a result of economic activity based on carbon energy being reduced. Address issues such as energy poverty by a massive upscaling of insulation of houses, particularly for those in low income. Invest in innovation and training for low carbon green jobs, and effectively begin the process of a new industrial revolution based around the principles of the Green New Deal and a just transition, so that workers, communities, consumers are not disproportionately badly affected as we make the transition away from coal, oil and gas in particular. So it seems to me that we should resist calls for returning to normal. And I do think that when we look at how societies, communities and states have reacted to the pandemic, it gives us some lessons or perhaps some elements of hope that we can deal with a much greater crisis. But what have we learned from the pandemic? Well, there are a number of things. One is that states do have agency, despite decades of neoliberalism and the promotion of that the market is best and privatization are the most efficient ways to organise production and consumption. We now see that states can move very quickly and have a lot of agency, particularly in the context of a crisis. We've also learned that populations can move and adapt quickly to new behaviours, social distancing, working from home, and other diminutions of our civil liberties, at least temporarily, for the sake of a much greater prize of reducing the chances of the most vulnerable in our society from contracting COVID-19. We found that agency is also possible in the context of finance, that there is perhaps a magic money tree, that austerity was a lie, that the state can find the resources. Often it's usually to fight wars, as we've seen in the mobilisation of a lot of people, munitions, men, women, and other affiliated army paraphernalia for the war in Iraq in 2003. But now we see the state mobilising to protect life. We've seen the state engage in what once was thought as impossible, utopian policies such as universal basic income, as they've implemented in Spain and Ireland and Britain in terms of furloughed workers and so on. We've also learned that it's possible to communicate complex issues to our populations visually. We're all now familiar with the idea of flattening the curve to try and stretch out the peak and lower the peak of the pandemic to make sure that our NHS and other healthcare systems are not overburdened as a result of so many people presenting with the virus. Well, I think we can learn from that and see, well, can we move from flattening the curve to actually bending the curve? And the curve I'm talking about here is greenhouse gas emissions, to show publics that there are ways in which through changes in our lifestyle, in transportation, reducing our intensity and use of carbon for our energy, considering reducing our red meat consumption, minimizing our production of waste going to landfill. There's a whole range of ways in which individual and collective action can mean that we can begin to bend the curve down of greenhouse gas emissions and begin to address the planetary emergency. We've also seen that there are positive short-term, perhaps environmental impacts of what's happened with the crisis in terms of air quality increasing in China, in Italy, London, indeed even here in Belfast, as people are driving less. And I do think there's something around seeing what in this crisis is positive and what can we learn from, what do we want to see continue as we come out of this crisis. We've also seen, of course, that there's been negative economic impacts. This has been an unplanned crisis, and therefore any of the transition elements around reducing our carbon use and so on have not been planned. And therefore it doesn't give us a good guide as to how we should plan our decarbonisation transition process. But we have to begin to have that conversation in our society about decarbonising our economies in terms of energy, in terms of food. Because the reality is that, we have become addicted as societies, structurally dependent upon carbon energy. So we need to move to a renewable energy economy. And that's what I think the advantages of looking at the positives in this pandemic are, in terms of how states can move, how populations can adapt to different lifestyles, different ways of working from home, and begin to see the possibility that another world is possible in terms of what would this transition look like that we're going through now if it was planned, if it was signalled in advance to populations, if there were civic assemblies to discuss how we should green and create a less carbon intensive, more inclusive society. Begin to offer a vision of a post-capitalist society, that we can see the end of capitalism as more possible now than the end of the world. Provocative ideas, but we should never let a crisis go to waste. And indeed, crises are opportunities for radical social, economic, and indeed cultural transformation. And perhaps that's what we're in at the moment. But it's all to play for. There is no guarantee that we will have a green and inclusive recovery. It is going to take lobbying and struggle and citizens to demand they want to build back better. So the pandemic has cancelled the future, but that's okay. It was a pretty bad one anyway. Thank you.
The COVID-19 pandemic has brought into sharp focus many of the troubling features we already knew about health disparities but have failed to address. During the 2009 flu pandemic, the death rate was 3 times higher in the poorest fifth of England's population than in the richest. COVID-19 is showing no signs of departing from that pattern, and because of the way the socioeconomic dice fall, this also has a racial dimension. Recent data from the UK's Office of National Statistics show that Black, Asian and minority ethnic populations are disproportionately affected by COVID-19. It has hit some of the poorest ethnic minority populations hardest, those in low-paid or unstable employment, who live in crowded accommodation and adverse neighbourhoods, have underlying health conditions, and for whom healthcare is less affordable or less accessible. For urban designers and environmental health researchers like me, this pandemic has sparked a debate about how our cities should be built, and perhaps more importantly, how they can better respond to current and future crises. Drawing from history, I reflect on key pathways through which urban design and planning must focus on evidence-based, health-promoting interventions in an equitable manner. If the past is any indication, disease outbreaks shape our cities. Some of the most iconic developments in urban planning, such as London's Metropolitan Board of Works and mid-19th century sanitation systems, were developed in response to public health crises such as cholera outbreaks. At the turn of the 20th century, public parks became popular in the United States as tuberculosis swept through the country. Now, COVID-19 is joining a long list of infectious diseases like the Spanish flu of 1918 and the Ebola virus disease of 2014, and it is likely to leave lasting impacts on urban spaces. The spread of COVID-19 in some of the world's dense, populous cities has raised questions about urban density. Crowding on sidewalks, in buildings and public spaces is thought to make physical distancing difficult or impossible and increase the risk of contagion. This critique against density goes back to the late 19th century when some American civic leaders embraced the notion that social problems such as disease and poverty stemmed from crowded and unsanitary conditions in cities. However, this idea may not be so clear-cut with regard to the spread of COVID-19. Emerging findings from my research show weak associations between high density and COVID-19 cases and death rates. Numerous hyperdense metropolitan areas, such as Singapore, Hong Kong, Tokyo, and Seoul, have succeeded in containing the spread of COVID-19 compared to low-density cities. Dense Asian cities in particular responded swiftly with public health measures such as testing, contact tracing, isolation, and quarantine. It appears that these classic public health measures can overcome contagion risk due to higher density. Density is likely just one of several key factors that determine how vulnerable places are to COVID-19, and it plays a smaller role compared to socioeconomic factors. The starkest indication of this is the issue of space, both private living space and the wider neighborhood public space. Being locked down for days on end may be easier if you have plenty of space indoors and access to outdoor spaces like parks, but for people whose living conditions are cramped, it is a much less appealing prospect. The UK's Office of National Statistics has reported that the percentage of homes without a garden is higher among ethnic minorities. There is a compelling link between outdoor exercise and a strong immune system, as suggested by the success of outdoor hospitals during the 1918 influenza pandemic. This search for fresh air and green space is glaring in the poorest neighborhoods of our cities, and it is likely to have negative implications for physical activity, mental health, and the severity of COVID-19 infections. With physical distancing likely to be the norm over the near future, we need to analyze how the design of our buildings, neighborhoods, and cities impacts health, social mobility, and disease control, among other factors, and how in the coming months, dense cities globally may need to adapt quickly. Cities across the world are already implementing temporary measures to make streets safer for walking and cycling, such as reallocating road space away from motor vehicles and lowering speed limits. Cities must embrace the opportunity and ensure that the positive developments in urban planning become permanent fixtures of our spaces. Tackling socioeconomic inequities is a core value for public health, but has not always been a part of emergency preparedness plans. It is now more crucial than ever to develop policies to create healthier communities equitably to strengthen our preparedness for future pandemics.
In an emergency, such as the current COVID-19 pandemic, governments have at least two important responsibilities. The first is to provide information to citizens about what's happening, why, and for how long. Secondly, governments must provide citizens with guidance as to what they should do, sometimes backed by legal penalties for non-compliance, and again, they should explain why citizens are being asked to do this and for how long. The UK government has a strategy, and at the same time It is committed, in the words of the Prime Minister, to maximum transparency. Yet in explaining the strategy to the public, the government has continued to insist on a single mantra that it is led by the science. There are two problems with this. Firstly, there is no such thing as the science. Scientists disagree, sometimes quite radically, and science progresses by contestation of and debate about competing claims. Second, science alone is not enough to justify a strategy. You need values. Indeed, science and values are often inextricably mixed. To give two examples, social isolation may, science tells us, work to reduce the rate of infection. But we need to ask a moral question. There are particular social groups, the old, the vulnerable, single, who will be particularly disadvantaged by social isolation. What then do we owe them by way of support? Second, a contact tracing app such as has been proposed for phones may work very well to reduce or mitigate transmission rates. But again, we need to ask a moral question. Is the possible loss to individual privacy by having such an app on your phone more than outweighed by the gains to public health? So a government needs to do ethics, even if it says it doesn't, and needn't do ethics, rather in the way that famously Alistair Campbell interrupted Prime Minister Tony Blair by saying, "We don't do God." So what is it to do ethics? In the first place, what one often finds is a shopping list of principles such as respect for persons, equity, minimizing loss of lives, maximizing benefits. But there are at least three problems with listing principles in this way. First, there is the question, well, why these principles and not some others? Doesn't it seem arbitrary to pick out these particular principles? And one is reminded of the famous joke by Groucho Marx, well, these are my principles. Well, if you don't like them, here are some others. Secondly, principles can conflict, and we need to know how to deal with such conflicts. How are principles to be ranked? Are some more important than others? Indeed, are some of paramount importance? And lastly, we need to know how to move from general principles to particular moral judgments. For instance, it's often said that in dealing with priority amongst COVID-19 patients, we should use a principle of equity or fairness. But what exactly does fairness demand in this particular situation? Does it, for instance, demand that we should give priority to the young over the old? So if a government must do ethics, we need people who are qualified, competent and skilled to assist the government in this way. And that is people who are trained in ethics and moral philosophy. There are examples in other jurisdictions of national ethics committees composed of people trained in moral philosophy who will assist the government in law and policy. The German National Ethics Committee and the French National Ethics Committee are good examples of that, but there is no such thing in the UK. It is not enough in this particular case to use committees of stakeholders or caring and compassionate citizens, the wise and the good, or whatever. We need people with a particular skill in the subject of ethics, just as science committees that advise government need competent and trained scientists to help them. Now bear in mind, this is not a case of people from on high offering ethical advice to the population that must then be followed. Rather, it is a question of helping the public and the government to make sense of the ethical issues, to render our judgments consistent and coherent, to tease out what are the relevant considerations and how they should be balanced. Above all else, ethics advice is something that should be done clearly and transparently. It is not something that should be done in locked rooms, unminuted and in secret. Because at the end of the day, consideration of ethical matters must be by the public in a transparent fashion. In this particular pandemic, we are going to face very difficult choices, and some of us are going to have to make more difficult choices than others. Those choices are essentially moral ones, and we need to know why they're moral ones, and we need to know how to address and resolve them. We need, in short, to do ethics.
I hope you've enjoyed those talks. That concludes our programme for this first Queen's University Belfast TEDx digital event. And I'm sure you'll agree that our speakers captured the spirit of TED. Thought-provoking and ideas-focused, we've heard about changes happening as a result of the COVID-19 pandemic and how this is affecting a whole range of areas of our lives. Our speakers have offered their informed observations on what the future might hold or could look like, and they've voiced their hopes for a future where we might learn lessons from this crisis and act upon them to make changes that will bring benefits to society. Thank you for watching the event online and sharing in this new digital TEDx experience with us. A word of thanks too goes to our TEDx Queen's University corporate partners, PwC, who've supported us in this new endeavour. And most importantly, on behalf of all of us, I wish to thank each of our speakers for their thoughtful, engaging talks. We hope to host a TEDx conference here on the Queen's University Belfast campus in 2021, and I hope that you'll join us for that. And do please keep involved with us on social media. Let us know what you thought of this event and send us your comments on the talks. You can keep us in the conversation by using the @TEDxQUB Twitter address, or you can email us your feedback to publicengagement@qub.ac.uk. These talks will be available online on our website, and we'll post regular updates on our future plans for TEDx events. So please do keep an eye out for our future plans. Please do stay involved with Queen's University Belfast, and thank you.